Thank you. So, good afternoon, everybody, and welcome to this session entitled What's New in Autoimmune and Cholestatic Liver Diseases. So, my name is Olivier Chazouillère from Paris, and it's my pleasure to co-chair this session with Michael Mans from Hanover and Ulrich Buyers from Amsterdam. So during this session, we'll have three back-to-back presentations. The first one by Michael Mans on autoimmune hepatitis. And as you know, Michael is a world expert in this field. The second one by Frédéric Neuvens from Leuven in Belgium, who is especially interested in the treatment of PBC, including obeticholic acid. And the third one by Ulrich Buyers on primary sclerosing cholangitis, and Ulrich has made many seminal work on different aspects of cholestasis, including sclerosing cholangitis. But without any further delay, let's move to the first presentation by Michael Mans on autoimmune hepatitis. And at the end of the session, we will have a general discussion, and please feel free to ask question by using the chat.
Many thanks for the kind invitation to speak to you on autoimmune hepatitis. These here are my conflicts of interest, and I want to give acknowledgement to a number of colleagues that I've worked with over the years on this topic. And I also want to mention the ASLD 2020 Autoimmune Hepatitis Practice Guidance and Guidelines Writing Committee. I have been a member of this group, and the latest ASLD guidelines were published in 2020 in hepatology. Some words on epidemiology of autoimmune hepatitis. There has been a 50% increase in incidence over the last decades, and the disease occurs in all ages and in all ethnic groups, with two peaks, one in childhood and one above the age of 60. The understanding of the pathophysiology is that there is a genetic background, a genetic predisposition, and that environmental factors like infectious agents and toxins induce an autoimmune process targeting the liver tissue, and that the genetic background leads to an imbalance of the immune regulation that leads finally to the autoimmune process triggered by environmental factors. The genetic background is mainly based on the MHC locus, and here in particular HLA-DRB1, 0301 and 0401, and it's regarded based on GWAS analysis a couple of years ago that about 50% of the genetic background is based on MHC locus and the other 50% on other loci. Some of them have been identified. This here is a cartoon out of one of our review articles indicating all the humoral and cellular factors contributing to the multifactorial autoimmune process, finally leading to the destruction of the liver cell. Some words on diagnosis. The diagnosis is based on clinical and pathological criteria and including liver histology. However, the laboratory parameters include autoantibodies, biochemical markers, and also the response to steroids at the initiation of therapy. The strength of histology is not only leading to diagnosis, but also for grading and staging and excluding other liver pathologies. There have been publications on scoring systems, mainly under the umbrella of the Autoimmune International Hepatitis Group. The first published in 1992, McFarlane was first author, revised criteria by Dr. Alvarez. But these complicated scoring systems are mainly used for characterizing clinical cohorts for clinical trials. Dr. Hennes and co-workers published in 2008 the most simplified scoring system, and Georgina Mieli-Vergani published on the pediatric population, hinting to the problem that there are specific characteristics in the pediatric autoimmune hepatitis population. This is that lower autoantibody titers are prevalent, that the cholangiogram should be obligatory to exclude the autoimmune sclerosing cholangitis, and that the family history is more important in pediatric than in adult patients. This is the diagnostic algorithm for autoimmune liver diseases based on autoantibodies and liver biopsy, and based on the AASLD latest guidelines of 2020. If there's a suspicion of autoimmune hepatitis, you should do autoantibodies in adults, mainly ANA, SMA. In pediatrics, LKM1 antibodies are of importance. And if these antibodies are negative, then you should use additional autoantibodies like SLA, Pianca, transglutaminase, and antimitochondrial antibodies to exclude primary biliary cholangitis. Liver biopsy should also be part of the diagnostic workup, in particular to look at interface hepatitis plasma cells rosette formation to support the diagnosis of autoimmune hepatitis, but also to exclude fatty liver disease and bile duct injury. There is some efforts now ongoing to replace the multiple autoantibody testings. In the US, mainly these tests are based on recombinant antigens. In Europe, we still use widely immunofluorescence testing. This is data from Dr. Taubert's group here in Hanover and Dr. Engel. They developed a polylactic IgG test in adult autoimmune hepatitis and evaluated it in a retrospective multicenter and a prospective cohort under the umbrella of the European Reference Network and the International Autoimmune Hepatitis Group. And they developed a test with a higher accuracy than single autoantibodies alone. And we will see whether this patented assay will be widely used. So overall, I come back to pre-treatment evaluation of autoimmune hepatitis and the recommendations by the AASLD guidelines. There should be a screening for extrahepatic autoimmune diseases like celiac disease and thyroid autoimmune disease. Vaccines should be administered according to the age-specific guidelines of CDC. There should be an eye on bone mineral density and supplementation of calcium and vitamin D, and transient elastography to look for staging of disease should not be applied in the first 6 months, because here the acute inflammation is maybe misleading. So I come to treatment goals. The treatment goals is biochemical remission. And this was first introduced in the 2010 AASLD guidelines. Here, for the first time, normalization of ALT/AST plus IgG was the goal. And here is a citation of 2 recent publications which underline the importance of complete biochemical remission. There's also data from the children population, and there is no difference between autoimmune hepatitis type 1 and type 2. Withdrawal of treatment is possible without liver histology. A persistent abnormal prothrombin predicts the need for liver transplantation. This is results of this publication, apart from the fact that also in children, complete biochemical remission is crucial. The role of histological remission may be even more important than biochemical remission, even in those patients where we see a biochemical complete remission. If the histological activity index is above 4, then this is associated with a reduced survival. Now, therapy. First-line therapy, as you all know, is steroid alone or together with azacitidine. According to related guidelines, if there is no cirrhosis, prednisone or the topical steroid budesonide may be used in combination with azacitidine. If there is cirrhosis, budesonide should not be used, prednisone with azacitidine, and a special group is acute severe autoimmune hepatitis, and I'll come back to this later. Steroids and azacitidine are associated with side effects. This has been well described, and here you see that both prednisolone and azacitidine are associated with side effects. In particular, steroids are associated with 80% of the known cosmetic and somatic side effects. Therefore, years ago, the topical steroid was evaluated, originating from Dr. Danielsson from Sweden. He showed that budesonide has a lower bioavailability, but still efficacy. And this is a study published in 2010, leading to approval of budesonide in combination with azathioprine, showing that at 6 months in double-blind study, that the combined endpoint, meaning normalization of ALT, AST, and IgG, in the absence of steroid side effects, that here budesonide was superior to prednisone. After 6 months, there was open label, and the prednisone group was switched to budesonide, and you see that steroid-specific side effects were reduced. In the pediatric population, the main steroid-specific side effect was weight gain. And as you can see here, switching after 6 months, the group from prednisone to budesonide reversed the weight gain side effect. So overall, the role of budesonide is, if it's used instead of prednisone or prednisolone, to reduce side effects in combination with azathioprine. Its worth is mainly in maintaining remission in non-cirrhotic patients. It's approved now in 23 European and non-European countries. Missing are long-term studies, in particularly on bone density. So the guidelines of AASLD here suggest that budesonide and azathioprine or prednisolone and azathioprine should be used as first-line treatment. If there is cirrhosis or acute severe autoimmune hepatitis, topical steroids should not be used. There's been a very recent publication as of this year from Spain, the retrospective analysis showing that there is no difference between prednisone and budesonide if there is the upper limit of normal less than 2. But overall, prednisone has benefits in this retrospective analysis concerning biochemical remission, and at the same time has higher adverse steroid-specific side effects. We will see how these data will show in prospective studies, but a very interesting publication. This leads to a publication from Netherlands, where we have contributed our cases and whether we need as much steroids as we use these days. And there was a comparison, 0.5 milligram per kilogram per day below or above. And you can see here on the left-hand side, no statistical significance whether you'd use high or low dose steroids concerning 6 months biochemical remission. Dr. Dalekos from Greece questioned whether we could use MMF instead of azathioprine. In particular, since 12 out of his 32 patients were switched from AZA to AMF because of intolerance or insufficient response. This data he published last year in Frontiers of Immunology shows that there were no significant difference between azathioprine and MMF. In contrast, at the end of follow-up, there was some advantage for MMF. We will see how this shows up in future studies prospectively. Now, monitoring treatment and disease activity. This is very important because biopsy we cannot do every day. And again, Dr. Taubert and Dr. Derben from our institution here, which is now headed by Heiner Wedemeyer, and you see here that he uses as a biomarker M65 measurement, and he really can show a cutoff at 305 units per liter, showing those patients with complete and distinguishing them from incomplete remission, which is important for the long-term follow-up of these patients and treatment guidance. So now I switch to acute severe autoimmune hepatitis, characterized by jaundice, INR between 1.5 and 2, no hepatic encephalopathy, and a significant number of patients at first-time manifestations show the clinical characteristics of acute severe autoimmune hepatitis. And we have not put enough attention on treating those patients and guiding those patients and asking the question whether and when we should give indication for liver transplantation. Histology in this publication by Dr. Reims either based on biopsy on explant histology. This is from Dr. Rahim's publication, JHEP reports, 9 studies, acute severe autoimmune hepatitis, 378 patients. They had predominantly prednisone or methylprednisone, variable responsiveness to steroids in this acute severe group between 36 and 100%. Survival was between 60 and 100%, and the need for liver transplant is up to 83%. You see on the right side that the recommendation by the latest guidelines is not to use topical steroids, not to use azathioprine, to use in adults 60 milligram of prednisone, and in pediatrics 2 milligram per kilogram per day, or give it IV. And in contrast to the chronic cases, you should do laboratory testing every 12 to 24 hours in order to see whether there's deterioration on liver histology. It's a very important unmet need, how to predict the responsiveness to steroids and whether patients survive. And here I want to cite a paper 2 years ago by Dr. de Martin from France, in the name of a consortium published in Journal of Hepatology, and they described the SOFASA score, survival factors for acute severe autoimmune hepatitis. And it's a retrospective multi-center study from France, and 128 patients diagnosed as acute severe autoimmune hepatitis, 115 received steroids, 23 in addition ASA or MMF, 66% had a transplant-free survival at 90 days. And these patients received steroids, no N-acetylcysteine, no plasmapheresis, and the SOFASA score is based on the delta, on the day 0 INR and the delta between day 0 and day 3 INR and bilirubin. And there has been a very clear cutoff at 0.9 with a high sensitivity of 84% and specificity of 88%. And you see if the SOFASA score is less than 0.3, there's a high predictability of survival. So now words on second-line therapy. If first-line therapy doesn't work, second-line therapy should be used, but none of second-line therapies is approved for autoimmune hepatitis yet. And the second-line recommendations are that MMF or TAC should be used to achieve or maintain biochemical remission, but the ASLD recommends prospective trial between MMF and TAC as initial second-line therapy, because so far prospective evidence is missing. In Europe, MMF is preferred. Now at the end of my talk, I come to third-line therapy. If first and second-line therapy do not lead to remission, we use biologicals. TNF, Treg, IL-2, IL-2 mutants, anti-B cell strategies. And I want to highlight this. Again, none of these third-line therapies is approved yet. Here is again the cartoon of the immunopathogenesis, and I've highlighted with red circles where the targets for the innovative biological therapies are. First, TNF. This is the largest series from Hamburg. You see that 11 patients, most of them had cirrhosis, that here in 6 out of 11 there was full remission. However, the side effect profile showed significant side effects on infectious symptoms. Now, IL-2. Low-dose IL-2 can induce Tregs, and Tregs are used in autoimmune diseases, and there is also experimental evidence that that may be a way in autoimmune hepatitis in third-line therapy. Here is a preliminary report on 5 patients, and you see that the Tregs, if you infuse them, host mainly to the liver and not outside the liver. There were no significant side effects, and low-dose IL-2 was shown, at least in one of these 2 patients, to be beneficial, to lead to biochemical remission via induction of regulatory T lymphocyte. At the very end of my talk, B-cell depletion. This is now the focus of therapeutic development for third-line therapy. Anti-CD20, the rituximab antibody, is used, and this is the largest trial so far. Retrospectively, we contributed our cases and no serious adverse events, 2 times 1 gram, 2 weeks apart, reduction of ALT and IgG, and at the same time, steroid reduction. In the focus now is B-cell depletion using the anti-BAFF receptor strategy. BAFF is a B-cell activating factor, and the level of BAF is associated with severity of autoimmune hepatitis and is decreasing under effective therapy. And therefore, it is logical that these data supporting the role of BAF should lead to the strategy using anti-B cell strategy, not only including CD20, but also using the BAF receptor axis. And here I just mentioned still ongoing trying ianalumab or VAY736. It's a monoclonal antibody targeting B cells and also the BAF receptor. And we are waiting for the results to be published later this year. At the very end, there are also antibodies directly the BAF anti-BAF axis. This is belimumab, just few patients that have been published from George Daleko's group, and there are some recurrent results, which hopefully we will see in a prospective trial in the future. So in summary, ladies and gentlemen, on B-cell depletion, it's feasible and rather safe. There is rituximab targeting CD20, belimumab targeting BAF, and also additional strategies that may be beneficial in the future. So based on promising results in other autoimmune diseases and several case series in autoimmune hepatitis, B-cell depletion therapies are at present under evaluation for treatment failures to standard of care or second-line therapy. So at the end of my talk, I want to discuss on the end of therapy. Can we withdraw therapy? We know that we can withdraw therapy in those patients that have biochemical histological remission, but still relapse is almost universal. And therefore, we really have to carefully work on long-term strategies to maintain remission without side effects. Thank you very much for your attention.
The topic of my presentation is primary biliary cirrhosis, what's new? As you know, UDCA is still the cornerstone for the treatment of PBC. However, in case of incomplete biochemical response, this can result in major complication in 30% of the patients after 10 years, as is illustrated in this slide. So the next question is, what is an incomplete biochemical response? And over the last couple of years, several papers have demonstrated that normalization of alkaline phosphatases and bilirubin are the strongest, one of the strongest predictors of outcome, of improved outcome in patients with PBC. And this probably means that in the near future, the target for treatment for PBC is normalization of alkaline phosphatases and bilirubin. But besides these biochemical parameters, recently we have also other tools to assess the prognosis of patients with PBC, and it is by fibroscan. As you can see here, there is almost a linear correlation between the liver stiffness level and the outcome of the patients. And for example, if the elastography value is below 8 at start of the observation, you have a pretty good outcome. In contrast, if the elastography value is above 15 kilograms kilopascal, this means that this results in a real poor outcome of the patient. As you're also aware is that currently we have two second-line treatments. First of all, the obeticholic acid, which is an FXR agonist, and then off-label use, bezafibrates, which is a PPR agonist. And recently, for both compounds, it has been demonstrated that treatment with obeticholic acid, for example, resulted in improved outcome versus the external control group. These are the patients who participated in the POISE trial, which is a long-term study assessing the efficacy of obeticholic acid, and the data were compared with an external control. And you can appreciate the really significant improved outcome. The same for bezafibrates, the PPR agonist, and that are data coming from Japan, where for many years they used the combination in case of poor response to UDCA, the combination UDCA and bezafibrates, and you can also appreciate improved liver transplant-free survival in patients taking the combination. However, especially in Europe, bezafibrates are available, but not in the United States, first of all. Secondly, bezafibrates have never
been developed specific for PBC, and nobody ever did those range studies. The common dose used with bezafibrates is normally 400 milligrams. Therefore, several companies developed a proper PPR agonist, especially as indication for treatment of PBC. And one of the most advanced compounds is seladelpar. And it is the outcome of the so-called ENHANCE study, which is a phase 3 randomized placebo-controlled study in which seladelpar 5 milligram was compared to placebo and a 10 milligram. And you can really appreciate it that with the highest doses of seladelpar 10 milligram, more than 75% of the patients has a successful composite biochemical response defined by the so-called POISE criteria. And if we look more in detail about the proportion of patients with normalization of ELP, and as already mentioned, probably this will be the new tool, the new goal of the treatment for PBC. And then you can see that around 25% of the patients has a complete normalization of alkaline phosphatases. And I will discuss this further. You can also see that there was a significant improvement in the intensity of pruritus. But if the tool, the goal is a normalization of alkaline phosphatases, you can clearly see that probably one compound as such has not the capacity to reach that particular goal. And that's the reason we and others try out whether obeticholic acid and bezafibrate, the two second-line treatment, if you combine them, thus there is an additive activity? And the answer is yes. This is a proper study published in Hepatology, and this was the long-term follow-up of the patients in my units who participated in the POISE. And you can see during long-term follow-up of this patient, there was a significant reduction in alkaline phosphatases. However, at the end of the 5 years follow-up period, the majority of the patients did not reach normalization of alkaline phosphatase. In contrast, at the moment, after 3 and 6 months, we add bezafibrate. In a substantial number of the patients, there was a normalization of alkaline phosphatases. And this has been confirmed in this retrospective study in which a cohort of patients from France, from Belgium, from Germany, data were all put together, and you can see that one compound as such was not able in the majority of the patients to normalize alkaline phosphatase. However, if you combine both drugs, obeticholic acid and bezafibrate, in addition to UDCA, in around half of the patients, you can reach a normalization of the alkaline phosphatases. But a patient with PBC is not suffering from alkaline phosphatases. He or she is suffering from pruritus, from fatigue. And in this regard, these data are quite important. This is a prospective study performed in the Netherlands a few years ago, in which they assessed the effect of bezafibrate versus placebo in the effect on pruritus. And as you can see here in this slide, in half of the patients taking bezafibrates, there was substantial improvement in the pruritus. This is versus placebo. And this fits already what I was already mentioned with the seladelpar data, which is also a PPR, in which, again, in this ENHANCE study, an improvement of pruritus was observed. And finally, patients are not only suffering from pruritus, they mostly are suffering from fatigue. And until now, none of the compounds, obeticholic acid, UDCA, bezafibrates, has clearly demonstrated an improvement of quality of life. These are the data from the CETA-NACSIP study, which is a NOX1 and 4 inhibitor, which does not have a direct anti-cholestatic effect, but it has a strong anti-inflammatory activity. And if you can appreciate here, in patients taking the 400 milligrams and the 400 milligram 2 times a day, there was a significant improvement in the degree of fatigue. However, these are preliminary data and needs confirmation. So in conclusions, the level of liver stiffness, in addition to a biochemical response, is an independent predictor of outcome in patients with PBC under treatment with UDCA. The combination of UDCA with obeticholic acid, approved treatment, UDCA with bezafibrates off-label use, improve the long-term outcome in patients with an incomplete biochemical response. That is based on two studies which I discussed, the PHC trial and the observations in Japan. One of the strongest predictors of improved outcome is normalization of alkaline phosphatases and bilirubin, which currently cannot be reached with one single compound. And therefore, the combination of obeticholic acid together with bezafibrate has an additive effect on the level of alkaline phosphatases. And this is what certainly we can use in the near future. And finally, the quality of life can be improved in patients suffering from pruritus with PPR agonist, and currently there are other molecules in the pipeline. And in patients suffering from fatigue, there are preliminary data who suggest that a NOX1/2 inhibitor has a positive effect on fatigue. And finally, the future for the treatment of PBC look really bright, because this is an overview of the drug approved or in advanced stage of clinical development for PBC, and the majority of these studies, at least in phase 3, are positive. So the future looks bright. I thank you for your attention.
Mr. Chairman, colleagues and guests, thanks first to the organizers for kindly inviting me. It's a pleasure to speak about what's new in primary sclerosing cholangitis. My disclosures. Primary sclerosing cholangitis is a disease of mainly younger males, as you can also see in this population-based large study performed in northern Netherlands, which shows the typical patient in the Netherlands. 2/3 male, 2/3 have an IBD, 92% here took ursodeoxycholic acid, and the liver transplantation-free survival of 21 years still is the best, now 10 years after publication, best ever reported in patients with primary sclerosing cholangitis. You also see the risks of malignancy, cholangiocarcinoma and colorectal carcinoma in this particular cohort. What we know from other cohorts, the histology typical with onion skin-like sclerosis around the bile ducts, and a not too dense infiltrate with inflammatory cells around the bile ducts. When you want to get a best overview on primary sclerosing cholangitis, pathophysiology and treatment, please go back to Dr. Carlsen's review from 2017, still a most comprehensive review on primary sclerosing cholangitis. He and his group took major efforts to find out the contribution of genetic factors in the pathogenesis of PSC, and their conclusion was that genetic factors play a minor role, but environmental factors and epigenetic factors may be more important. This study from Newcastle clearly shows this, underlines this. Here, the authors, Dr. Dyson and colleagues, looked at the spatial clustering of people with PABC and people with PSC in northern England. And what you can see, whereas in PBC, you have a clustering in urban areas around Newcastle, the opposite is the case for primary sclerosing cholangitis, where you have a clustering in rural areas. Other factors, potential factors, Dr. Adams and colleagues' hypothesis from Birmingham, aberrant homing of intestinal T cells may play a role in the pathogenesis of PSC. Then cholangiocyte vulnerability, we proposed the bicarbonate umbrella hypothesis, and Dr. Keitel's group clearly showed that GGR5, which is important for stabilizing the biliary bicarbonate umbrella, a bile acid receptor, when activated, stimulates bicarbonate secretion, is defective in PSC. Immune cell crosstalk, portal myofibroblasts activation, and stellate cell activation, which contribute to fibrosis formation around the bile ducts and in the liver. And finally, 10 to 15% on the long term will develop cholangiocarcinogenesis. And the recommendations, clinical recommendations, which our clinical practice guideline committee summarized in the summer 2022, are annual imaging of liver, bile ducts, and gallbladder, is recommended. Annual screening colonoscopy, when IBD is known, is recommended. And screening colonoscopy every 5 years when IBD is not known is recommended. This is nothing new. We also had that in former guidelines. Regarding treatment, again, the discussion around ursodeoxycholic acid, should we give it, shouldn't we? Here in the Netherlands, we broadly give it. Urso at doses of 15 to 20 milligram per kilogram per day can be given, since it may improve serum liver tests and surrogate markers of prognosis. Available data does not allow for a firmer recommendation. We do not have long-term prospective studies of adequate size and duration so far, also after 30 years. Endoscopic balloon dilatation in relevant strictures, please don't forget antibiotic prophylaxis for ERCP, and finally, the only curative treatment, liver transplantation. This is 30 years ago. 1 year before we published our first pilot study in PHC on ursodeoxycholic acid, Olivier Chazouillier also performed a pilot study, and we both saw a clear-cut biochemical improvement in our patients treated, including prognostic markers in primary sclerosing cholangitis. This is the only long-term retrospective study where so far data have been shown, at least at the EASL meeting in 2020. I didn't see the final paper. In this Japanese cohort, you appear to see an improvement in long-term prognosis, but we have to wait for final publication of this paper. The mechanisms as we see of URSO, as we see it in 2023, the stimulation of hepatocellular and cholangiocellular secretion by enhancement of transporter density in the apical membrane of the hepatocytes, but also in the cholangiocytes, and bicarbonate secretion, leading, among others, to stabilization of the biliary bicarbonate umbrella, which inhibits invasion of bile acids into the cells. Which other therapies are under evaluation? Vancomycin has shown promising data in children, as shown by the Stanford group, and there is now a phase 3 trial on the way. Ursodeoxycholic acid, positive anti-cholestatic effects in a phase 2 trial. Now phase 3 trial, the inclusion of 250 patients has been finished, and we are waiting eagerly for the results. Dr. Trauner is the PI of this trial. FXR agonists improving cholestatic markers, steroidal like obeticholic acid, and non-steroidal FXR agonists like cilofexor, both improving cholestatic markers, unfortunately also inducing itch in some patients, or worsening itch in some patients. FGF19 analogs, very interesting, aldofermin, improving fibrotic markers in a phase 2 trial, but not cholestatic markers significantly. And finally, PPAR agonists. A prospective study is running in Paris and in France. And I want to show you another aspect. Many of our patients with PSC suffer from pruritus, and we studied patients with severe to moderate pruritus, the effect of bezafibrate in this trial published at the end of 2021. We clearly saw an improvement in itch intensity in the group, 74 patients with PSC and PBC treated with bezafibrate in versus placebo. And also a secondary endpoint, overall improvement of itch was markedly improved by bezafibrate over the treatment period, but came back to the former activity after stop of treatment. Also, subgroup analysis showed in sclerosing cholangitis a significant effect, but also as it showed in PBC, and that we already knew for mild pruritus from the Paris group. So our conclusion for treatment of pruritus in PHC, pharmacological treatment of moderate to severe pruritus in sclerosing cholangitis with bezafibrate or rifampicin is recommended. This is the group, the committee, which came to this conclusion under the wise leadership of Olivier Chazuyer. Another summary is cholestyramine, naltrexone, and sertraline can be considered as third-line therapeutic approaches in case first-line treatment is not tolerated or ineffective. So this shows our summary, potentially promising factors where we have to wait for phase 3, the results of phase 3 trials, vancomycin, nor also PPAR agonists, potentially FGF19 analogs. And we know liver transplantation is at this moment the only curative treatment. Thank you for your attention.
Okay. So thanks a lot. We see whether we have questions. Until we get questions, I have a question for Frederick. We have these different criteria for response after 6 or mainly after 12 months. And you have clearly shown that the combination of urso with either obeticholic acid or bezafibrate has advantage concerning normalization of alkaline phosphatase. Will we treat every patient in the future with combination, or will we individualize treatment? Or will we wait after 1 year and then only treat the suboptimal responders?
Indeed, a very good question. I can only share some preliminary data from the global PBC group about when we have to switch to another treatment. And this is when to switch to second-line treatment in patients treated UDCA. And there are now data showing that we should not wait 1 year, but already after 6 months can make the decision whether these patients is not a candidate for second-line treatment. Obviously, for the other compounds, we don't have this data yet. But for example, many years ago, when the POISE criteria were developed, at that time, we did not have the possibility. We only had 1 drug and a possible second drug. But I'm pretty sure soon, at the moment, several drugs are coming on the market. We will be able to come to the endpoint normalization of ELT in ELP, alkaline phosphatase. In fact, any change in alkaline phosphatases is associated with an improved outcome, and a certain cutoff on how much the reduction should be, well, it's very difficult. At that time, again, I said with the POISE, we had to make that, but in fact, it is much more easier taking the normalization of alkaline phosphatase. By the way, all the drugs which I discussed also have a significant effect on ELT. And in the majority of the patients who respond quite well to duotherapy, for example, they have even a complete normalization, both of gamma-GT, transaminase, and alkaline phosphatases. So I'm pretty sure soon, with the availability of different compounds, the new goal should be normalization.
Thanks. Will we select patients that we start on combination therapy in the future?
Well, there is still a discussion at which moment we have to switch. Currently, in most of the countries, it's 1.5. Patients who stay with alkaline phosphatases level above 1.5, I think it makes sense to select them for second-line treatment. And you never know for second line, that means that at the end, some of the patients will end with triple treatment, UDCA, which is still the cornerstone of the treatment of PBC, bezafibrates, mostly used now in Europe, whether or not obeticholic acid.
Thanks.
So Michael, we got a very practical question. when if autoimmune hepatitis is suspected, but the patient over 60 years old doesn't want a liver biopsy. So what do you do?
I mean, this is a also interesting question. I think the patient above 60, in particular, if it's a female, which are most of the patients, then we fear bone disease, giving them steroids. Therefore, a biopsy underlying the diagnosis would be very helpful. But if he denies the biopsy, then certainly FibroScan in combination with serological markers of autoimmunity, IgG, should be enough to induce treatment. And here, if the patient does not have cirrhosis, I would prefer topical steroid budesonide in combination with azacitidine.
And still regarding liver biopsy, so one major issue is when are you allowed to stop immunosuppression? So in your clinical practice, do you perform liver biopsy on a routine basis, or?
Yes. I mean, there are clearly data out there that even in normalization of biochemical markers, there may be histological activity. And if you have, I mean, the majority does relapse, and over time, more and more relapse. So you should be very cautious to stop treatment. And I would try to take every effort and convince the patient to have a biopsy, because stopping treatment and having a relapse, in particular the elderly, may be dangerous.
Maybe I can take over a question from the audience. For PHC, are probiotics of use in primary sclerosing cholangitis? I don't know convincing data about that. The use of vancomycin, this is not really placebo-controlled trials, what we have in children. There is the discussion, is it really an antibiotic effect, or is it maybe more an immunomodulating effect of vancomycin within the intestine? This is open for discussion, and we don't know that at this moment. And we have to wait for this controlled trial in the US before we would like to give an antibiotic over years to our patients. So this is open to discussion, but probiotics, no convincing data.
So, Ulrich, we got another question from the audience regarding PSC. So, for screening for cholangiocarcinoma, is MRI once a year enough?
This is a very difficult question, and when we have discussed it also in our EASL committee, which you chaired, Olivier, extensively, and we know that none of our techniques or screening tools which we use is enough. So we try to optimize our screening, but MRI with contrast combined with MRCP is one of the tools. We can't recommend it for 32 countries all over Europe, because not everybody has these tools. We also discuss certainly long-term follow-up with CA19-9, no good data, but still I myself do it in the individual patient on the long term. But at this moment we are still not good enough, I would say, but we try. So MRI, MRCP, at least in patients with advanced disease, annually, you should strongly consider. But look also for the gallbladder, and ultrasound is the best for the gallbladder. 3% of 2 large cohorts had gallbladder carcinoma in PSC.
Here's a question on overlap of autoimmune hepatitis and PSC. I think here we have to distinguish between pediatric and adult population. Georgina always made the point that every patient with autoimmune hepatitis diagnosis should undergo MRI. On the other way around, if you have adult patients with a PHC, in particular if ALT is elevated, biopsy has to decide. And it's always a difficult question whether to give steroids or not. And I think here you should give steroids or immunosuppression if there's histological evidence for autoimmune hepatitis.
Yeah, I fully agree, Michael.
Yeah,
may I comment on that? Because currently within ERN Rare Liver, there is a project about better definition of overlap. Because it became clear that at the moment we did not have second-line treatment. A lot of the patients with a poor response to UDCA were considered as a possible autoimmune hepatitis and were treated with corticosteroids. However, what you see now, if you treat PBC patients properly, even with autoimmune feature on histology, you can reach complete normalization of liver tests, including ELT. That means that probably in the past, we overdiagnosed the overlap syndrome, but obviously PBC is also an autoimmune-like disease. It may make sense. Just the opposite data from the Netherlands many years ago show that in case you have autoimmune hepatitis with some bile duct damage on biopsy, if you treat them properly with corticosteroids, for example, also alkaline phosphatases are normalizing. So with the availability of much more drugs currently, we have certainly critical review, and our chairman is obviously the expert about overlap, but nevertheless, we have critical reassess the diagnosis of overlap in a considerable number of patients, certainly with PBC.
Yeah, I agree. It's a very complex issue. And I think in patients with overlapping features, we have to treat first the dominant disease. So I think when cholestasis is dominant, we have to start with anticholestatic agents, and indeed you can see a marked decrease in transaminase levels, and with only anticholestatic treatments. So I agree.
Maybe if I may, question from mine to Ulrich. You mentioned the endoscopic intervention of dominant strictures, and there is this one paper that you should have scheduled dilatation versus treating patients once they reach complications like cholangitis. And there's this multi-center study where Amsterdam and Oslo, I think, were the leading centers comparing papillotomy versus balloon dilatation without papillotomy. May you comment? Would you like to comment here?
Yeah, it was a study. I think it's important for the clinical management. It was a study initiated by Cyril Ponsioen from our unit in Amsterdam, and they compared then balloon dilatation versus short-term stenting, and one thing was that not everybody underwent polypectomy, papillotomy before balloon dilatation and stenting. But what came out in this study was that there were many more complications with short-term stenting than with balloon dilatation only. So, and the result was the same. So the clinical result was the same in the biochemical result. So we today recommend balloon dilatation when possible, and only if this is not enough, then additional short-term stenting. But the study clearly said the balloon dilatation has less complications, same efficacy, less complications in comparison to short-term stenting.
I think this is a very important result.
Very, very important clinical results. So we also do balloon dilatation, I think.
Right.
Mm-hmm. And antibiotics. Don't never forget the antibiotics in PSC.
Yeah, sure. So unfortunately, it's too short session, I think, because we are running out of time. So I think I thank the three speakers for their excellent talks and the audience for their questions. So unfortunately, we have to stop now.
Okay, thank you very, very much, Olivier, and all the friends, and Mark for inviting us, and Patrick. We enjoyed it.
Thank you very much, and thank you for a very good
Mark,
session.
and Mark. Yeah.